or all the other physical comorbidity, they are much lower than that. So the top 2 or 3 comorbidities are mental health usually. So what is depression? Depression are very common. They can present as a disease onset, but usually comes up later. So not at the beginning, but it's not associated with any disease course, but we usually see them as coming later on. And, we find comorbidity related to fatigue, where quality of life gets worse, and that has an impact on also compliance with treatment, which is very important there. How common it is, we're talking about 25% when we put everything together. And, we try to find at times, they say lifetime prevalence can go up to 50%, but, more or less. Is that the medication? Because a lot of people usually blame that on the interferon beta, and it's not. So they've done a lot of studies around that, and they discovered that, the treatment itself is not, however, still screen for depressive symptoms when you start that, because, our knowledge today might change tomorrow, might change the day after. So we have also to keep an eye on that. So the local data, again, some study from SKMC. I think we have one of the people who's done this study, Dr. Mustafa Sha'ra there. But local data didn't find any increase rate in here. I don't know why. I challenge again, but they said that the data. So they found it is similar to general population, in 2 of the studies at Sheikh Medical City. What they tell me, they are so amazing doctors there, so they keep their patient happy, so they don't get depressed, but I don't know. At least that's what we have in the local data from SKMC.
I think it's because of the control. We use the control technology of
okay. No, but Dr. Tawfiq didn't tell you that. So now we know the control. If you work at SKMC, you have a much higher rate of being super happy. But yeah, I wouldn't comment there. So anyway, so we think there's more of brain pathology there rather than, just like by chance with MS because of the core features there. But brain pathology can only explain about 40% of that. So what should we do? Recommendation of treatment. You always, for this and for everything else, you have to always to screen for depression. PHQ-9, I'm sure almost everybody knows that. And if you don't know PHQ-9, please just go download it from the internet, and it is in all languages, it's validated. It's a good screening tool for your patient. And if you want to go further, and you have another 1 minute free to deal with anxiety, do the GAT7, and then the others a little bit more of a specialist. Treat any organic cause, obviously, there, and ask about past psychiatric history, because if you have past psychiatric history, this number or ratio of whatever I was telling you about would double or triple at times. So there's a high risk of relapse there. So we need to keep an eye on this, And it's very important to see how is that impacting the family, because with all those conditions, as I said, the family suffers as well. They suffer a lot there. And pain is very, very important to screen for, because usually we see when people they have pain, they're more likely to have worsening of symptoms of depression. So SSRIs, again, they're first line of treatment. If I'm going to look about all the studies there, and we need to make sure, because there are higher rate of bipolar there, we need to make sure when we start people on an antidepressant, there's no history of bipolar mania or mania, which is quite difficult to assess at time because of those symptoms that come with, the MS, with the laughter and the manic features there. So we need to be able to differentiate that. They talk about, a lot of studies, sertraline, venlafaxine, duloxetine, a lot of things that we can use there, but, they're all almost, as equal in efficacy as each other. ECT we can use with all the 3 conditions. There's no contraindications there, especially with active suicidal thoughts. CBT is a psychological treatment, cognitive behavioral therapy, which is highly recommended as the main treatment from psychological intervention because it works, and this really works. And usually we use that in conjunction with medication, especially when we have more of moderate to severe cases. This is a little bit of those studies that whether it touched the line or not. So I'm going to go to suicide. Do we think we have a higher rate of suicide with MS? MS. slightly. So let's say 0.05%, 1%. So it's interesting. If you look at this, we find 28% here to 0.3% here to 5 times here. It's amazing. We don't know. But when you see all this range, it tells you that, yes, we don't know much, but there is quite considerable number of people. People think it goes between double to 7 times more. But we talk about suicide is a rare phenomenon. But again, we have to keep an eye on that. Cognition with MS. I think cognition is one of the things that we need to learn a lot about it. Why with MS? Again, this is about more than half of people, they have problem with cognition. Start with mild and then goes all the way to 10% to be quite severe. And even, MS without any physical disability, we find cognitive impairment in about 40%. So we talk about cognitive problem is a huge there. And we need, we cannot kind of forget about that. And that's in all type of MS. IQ decline from pre-morbid estimate. So again, we're talking about it's a progressive disease, and impairment with information processing is one of the main problem. Cognitive impairment is related to depression as well. So when I talk about this high number here, so when I have problem with cognition, it should be one of the warning signs. Say, okay, hold on. Is there any depression here that's making things worse? And this is very important not to ignore that.